Hello, my name is Rob Jackler. I'm a professor of otolaryngology and neurosurgery at Stanford University, where I've been for the past 20 years. I'll give you a little background about my journey as a skull-base surgeon. I trained in otolaryngology head and neck surgery, and then I did a one-year neurotology fellowship in Los Angeles at the Hauser Institute. And over 35 years ago, I started to practice at the University of California, San Francisco. And I had a wonderful group of neurosurgeons who were warmly supportive of me as a young neurotologist. We got very busy very quickly in doing all sorts of different kinds of tumors in this area. And I have continued throughout my career in that way. It's a team sport, if you will. And I've worked with a variety of wonderful colleagues throughout the years. I kind of grew up with skull-base surgery as a field. When I was a medical student, a CT scan came around. When I was a fellow, MRI came to the forefront. And really, high-resolution imaging is what allowed us to plan rational trajectories to complicated tumors in this area and allowed the field to mature. And it's gone through an evolution over the last several decades. And I thought that as I look towards my retirement from clinical work at the age of 70 in a year, it was a time to reflect back on this journey and some of the lessons that I've learned over the years. Now, of course, minimally invasive is central to what we do. However, this is not where the history began in the late 19th and early 20th century. This is from Fedor Krause's 1907 book, looking at cerebellopontine angle tumors, Klein, Hidden, Bruckenwinkel, and his German. And you can see using a deaver, a retractor, or some such, pulling the cerebellum. It was often resected in those days. The key instrument was your finger that worked around the tumor and then pulled it out. Clearly, this is something at the very beginning of the dawn of neurosurgery with very huge tumors and very high mortality. To illustrate, there's this wonderful movie from 1954 featuring Sir Lancelot Spratt. Those of you in the UK may recognize the setting.
Morning, gentlemen. Good morning, sir. Not late, I hope. Not at all, sir. Just lie still, old fellow. Showcase to these young doctors here. Take his pajamas off, sister. You, examine his abdomen. Take that grubby fist away. The first rule of diagnosis, gentlemen, eyes first and most, hands next and least, and time not at all. Have you looked? Yes, sir. See anything? No, sir. Very good. Carry on. Gently, man. Gently. You're not making bread. Don't forget, to be a successful surgeon, you'll need the eye of a hawk, the heart of a lion, and the hands of a lady. You found it? Yes, sir. Well, what is it? Blood. Well, you make of it. Is it kidney? Is it spleen? Is it liver? Is it dangerous? Don't worry, my good man. You won't understand our medical talk. What are we going to do about it? Cut it out, man. Cut it out. Where shall we make the incision? Nothing like large enough. Keyhole surgery. Damnable. Couldn't see anything. Like this. Now, don't worry. This is nothing whatever to do with you.
So it illustrates the thinking in the mid-20th century. And what I would like to do is to begin talking about the role of art in skull-base surgery, not just the surgical art, but the literal art of how one teaches it and understands procedures. Now, we all use video and we all use still pictures, and certainly the image on the left is about as clear of an eighth nerve tumor as you can get. However, with illustrations, when a surgeon partners with an illustrator, you can show so much more and simplify things by removing the extraneous. And it's a way of giving people an intellectual framework for the steps necessary for optimal surgery. Of course, real surgery is more important than these kinds of images, but they do give the person seeking to learn and refine their skills a way of quickly assimilating information. Now, all of the thousands of illustrations that have been created over recent years, really 3 decades, both in neurotology and Skullbase and also in more conventional otology, are available, but they're also available not just in the book form, but online. And if you Google Stanford Skullbase Surgery Atlas, all of these images are available. You are warmly welcome to use them for teaching purposes, for non-commercial purposes. I'm delighted when people make use of this as a resource for teaching in your home institution. Now, there's a history of collaboration between medical illustrators, professionally trained, and also surgeons. And here, Harvey Cushing, who was one of the fathers of neurosurgery in America, and Max Bradel, a Johns Hopkins illustrator. And here's an example of their illustrations, hardly a minimally invasive approach to tic douloureux and the trigeminal ganglion, but still just beautiful artwork from 1915. But of course, Cushing and Bradel also depicted the beginnings of minimally invasive surgery. And Harvey Cushing here in 1912 is shown imaging an approach to the hypophysis through the nasal cavity. Now, there were important anatomists, of course, who did beautiful drawings of the cranial base, which help us all to learn very much, both its osteology and its nerve and brain interfaces. And here's Eduard Pernkopf of Vienna. He makes beautiful drawings, but if you'll notice in the lower corner, the signature of his illustrator, Franz Brathke, and you'll see that in 1944, it was the 4 and the 4 were shaped as an SS. And in fact, both Pernkopf and Brathke were dedicated Nazis. And many of these cadavers, it's thought, came directly from the gas chambers that allowed these dissections. So it's an interesting ethical quandary whether such beautiful work should be done given the ignominious derivation of the work. Frank Netter is unusual, and he's a physician, not a surgeon, but also an illustrator. And his illustrations in our area are fairly simplistic and sometimes erroneous, but nevertheless very popular as teaching tools. Really, the master in our area of illustrations in many ways is Al Roten of Florida, together with David Peace and Robin Berry. And his opus was put together in this large book from the Congress of Neurological Surgeons. And it's a beautiful work of studies, individual studies of anatomical regions. My partnership has been with medical illustrator Christine Graylap over the last 3 decades. And what happens is, I do the drawing and I have no artistic skill whatsoever. And then we do a series of drawings illustrating the steps. Chris, for many years, would do pencil drawings. We would change them. Now, of course, it's done digitally. Chris also works as an illustrator. If you're interested in someone to help you with your papers, she can certainly help illustrate your works as well, if you wish. So I'd like to share some cardinal lessons learned over these decades, but also then hone in on a series of individual procedures that are core procedures within posterior and lateral cranial base surgery. Now, I have to begin by saying the term skull base surgery is wrong. It isn't really about the skull base. Most of these procedures are about creating minimally traumatic openings to inaccessible intracranial disease, often along the brainstem, the midbrain pons and medulla. The term transbasal craniotomy is probably more accurate, although I'm not proposing we change what we call ourselves. So the fundamental concept of transbasal craniotomy is removal of bone to minimize or eliminate the need for brain retraction and give access at a depth and angle of view favorable for optimal microdissection with neural preservation. Now, what's the difference between anterior skull base surgery, which I don't do, and posterior lateral? Very simply, the anterior skull base surgeons benefit from having a beautiful pre-made pathway to the middle of the head through the nasal cavity. And you'll hear from Juan Fernandez Miranda shortly. He is a master of this and has made all sorts of advances in terms of removing very adventuresome tumors in this way. Whereas in the posterior lateral, we have to create areas around the petrous ridge and petrous pyramid to augment pathways towards the structures in the posterior and middle fossa. The reality is, when I look back at the beginning of my career, people were showing, look at this big surgery I could do, look how much I would do. And in fact, really, it was often practiced with excessive vigor and sometimes, 12 centimeter openings for 3 centimeter lesions. Today, it's become much more refined, I would say, over time, and much more patient-centric. In general, cranial-based surgery has a limited use in high-grade malignancy. For example, an adenocystic carcinoma encasing the cavernous sinus, surgery is not likely to cure that. There are rare instances, in this case, a sarcoma in a child that, as you can see, is surrounding the carotid artery and in the petrous bone. The medical oncologist wanted us to remove the dural interface and push it back, which we did. And this child has done very well over many years. But it's an unusual circumstance. Occasionally, aggressive surgery for malignancy is warranted in like temporal bone cancer, sometimes chondrosarcoma and chordoma. So CSF leak in the world of cranial-based surgery can drive you to drink. There's no question about it. I would say in big cases, about 10%, regardless of techniques. And it is mostly not because you didn't close well, because the very best closure or obliteration of a tract is defeated by transient hydrocephalus or lasting hydrocephalus. And it's a hydrodynamic kind of thing. The other thing I would point out that when people have delayed onset CSF leak, 3 days, 5 days, 7 days later, they're at their peak of CSF pressure for a while. I've become very conservative with those and give them a little time, obviously fluid restriction, Diamox, et cetera, whatever. But I give them a chance to prove that it's going to be persistent before I crash in with another surgery. Now, lumbar subarachnoid drains are a useful tool. We typically leave them in for 3 to 5 days, but not longer for concern over catheter infection. Some people want to control the outflow and put it on an IVAC pump, reversing the effect of the pump. I think that's a bad idea, and I'll explain to you why. Think about the CSF space as a water balloon with a pinhole in it that's gradually healing over. Every time you have a transient, when a person strains at a bowel movement, when they lift the bar to get up out of bed, you're squeezing the water balloon and you're popping off that cork, if you will. Having a continuously open flow through the LSAD, every time you strain, it squirts into the bag rather than pressurizes, and it takes the pressure off the healing pathway. So I'm not a big believer in that. The second thing is I'm not a big believer in clamping. If you've reached the end of a 3, 4, 5 day period, whatever period you're comfortable with, and you want to see what's going on, take the catheter out. 2 reasons. If you clamp it, you get a sudden rise in pressure in many of these folks. If you take it out, there's a rent in the dura of the conocoina, which leaks for a little bit, which is healthy. The second thing is, the only reason to clamp is if you're going to reopen it for another 3 to 5 days. And that's probably beyond the time that you would want to leave a single drain in. So by taking it out, if they continue to leak, you're either going to surgery, you may be placing a new drain once this, 24 hours have gone by. Meningoceles are best prevented by opening as few tissue planes when you connect in the neck. Head and neck surgeons tend to want to elevate flaps and things. You don't want to do that when you have CSF continuity above. And be conservative with these. Don't start sticking needles in them because you're going to break sterility, but also because they'll just refill. Usually repair is unnecessary. It can take a couple of months, but they usually resorb. The vast majority of tumor surgery I can do in a single stage today. Rarely do I 2-stage tumors unless they're fundamentally, very high in anterior and very low in posterior, because that second operation can be even more difficult for the patient and have higher complications. Carotid resection. There was a lot of discussion in the 1980s about carotid resection, predicting it with balloon occlusion, xenon CT, and things like that. I almost never will consider carotid resection. In benign tumors, you can leave a little bit on it and radiate if necessary. Number 2, there are radiation and surgically recurrent chondrosarcomas and chordomas. On rare occasions, you might consider taking the carotid if you're at the end of the chain. But really not a lot of need for that. The Doppler is very important. When you're working around major vessels like the carotid, sometimes even the basilar artery, having a mini Doppler available to help identify where it is. It's also helpful in knowing whether there's sigmoid sinus occlusion or thrombosis when you need to. As a general rule of thumb, when working intracranially, most veins are inconsequential. And, here's Dandy's vein along the fifth nerve being taken. Rarely will that cause a difficulty. However, the bridging cortical veins, particularly the vein of Lebet, is different. And you can see Lebet can have various courses directly down into the transverse sigmoid junction area or come down along the tentorium. And if you get a venous, divide the vein of Lebet, you will sometimes get a venous infarction of the temporal parietal region. Now, the important thing that I learned was that, some Lebets come straight on down and enter that area. Others come down and run in the leaves of the tentorium. So as we'll be talking about later, when you connect the posterior and middle fossa by cutting the tentorium, I like to do is see the Lebet course. And when I cut straight forward. I don't cut back because I learned this the hard way by cutting an intra tentorial vein. However, arteries are different than veins in the posterior fossa. As a general rule of thumb, ICA, pica, superior cerebellar, you want to save all of those as much. Obviously, those are very important. One would never take them on purpose. But some of the vessels that live, for example, in this eighth nerve tumor, it's very nice to try to save every bit that you can. Take the time to dissect it off. Some are obviously tumor vessels, but it's always a good idea to preserve the arteries. Now, people talk about anterior inferior cerebellar ICA as having a loop. But in fact, there are two ICA loops coming out of the brainstem, usually from the basilar, sometimes from down at the bifurcation. It has a loop with a series of perforators into the pontomedullary junction. There's a second loop that comes laterally towards the internal auditory canal, and as such, it gives the nutritional blood supply to the inner ear. Now, if you cut the proximal loop, you end up with a very serious pontomedullary infarct that in the days before the ICU was not survivable. But if you cut the lateral loop and you bipolar it, you can get a limited cerebellar peduncular infarct. And in my experience, when people have an unanticipated degree of cerebellar dysfunction, it's often from this. And you'll see a limited, right in the middle cerebellar peduncle, a limited area of ischemia. People talk about the middle fossa approach to the internal auditory canal as one to see the entire IC and expose an entire tumor. In fact, as many of you may know, this is tricky because you've got the facial nerve on the top, but also the fundus portion of the tumor is frequently blocked by the transverse crest. So one has to be prepared to do a blind underneath dissection in a tumor that goes way out to the fundus. Now, I would say that large tumors in the 2.5 to 3 centimeter and up range in the cerebellopontine angle have a very high rate of facial paralysis afterwards, even in the hands of the very best experts, if you do radical removal. And so what I have evolved to is that much of the time with very large tumors, I will do either a subtotal, leaving a rind like this of the a long 7, or a near total. If you just leave a little tiny tag right outside the porus, that has a 3% chance of growing. If you leave a big rind like this, it's usually 8 millimeters thick, that will form a little nodule after 6 months to a year. Most of the time it won't grow, but about 30% of the time it will. And if it forms that nodule and you see it growing, we then clean it up with stereotactic radiation. So here's an example of a large tumor. This patient did very well and came out with a facial function. And this rind forms a much smaller ball over time, and then you observe it. And if it in fact grows, then CyberKnife has a very high rate, or Gamma Knife, of controlling the remnant from future growth. As a general rule of thumb, we surgeons tend to operate too much. I know this in my career earlier on, and I've seen many young surgeons When you're young, you operate to fill your calendar. You also operate to prove your mettle. But in fact, and this is true of radiotherapists, we've all seen, patients who are 70 with a little intracanalicular tumor that are radiated before any period of observation or following. As I got older, and I think this is true in general with surgeons, I'm more conservative. Many patients I'm willing to follow. This is true with a wide spectrum of benign tumors, and that willing to be conservative in the surgery that I do in a sensible way. So I just urge you to keep in mind what you would really want for yourself and what you would want for a family member. If I look at the sweep of skull-base surgery, it used to be bigger is better. Look what I can do. And they'd show an MRI scan with this enormous tumor removed. But if you look closely, the brainstem doesn't look good. The cerebellum and is trashed and that kind of thing. Today, less is sometimes more. Look how well the patient did over time. Cranial-based surgery to someone beginning in it can seem very complex, but in fact, looking at each individual tumor, a rational means exists that you can figure out. Excuse me, I'm just looking at the time here. But you can rationalize appropriate ways of doing the surgery. Now, let's start with jugular foramen approaches. Now, I'm going to go through these rather quickly. Anyone who wants this slide set is welcome to it. I'll give it to the organizers. You can email me at jackler@stanford.edu. I probably won't get through all of this, and we'll cut it off at the time, but I'm just going to go through rapidly. You're generally familiar, I'm sure, with the jugular foramen. As with many cranial-based tumors, there's an intracranial and an extracranial component in some. This is a view from my book on tumors, and you can see it's a surgical view, followed by an axial as an imaging coronal view. And this shows a paraganglioma from the jugular bulb, so-called glomus jugulare tumor. The second most common tumor in the jugular foramen is a schwannoma, and you can see this within the foramen or bilobed intracranially. And then finally, meningioma, and these mostly come either off the lower clivus and invade from medial or off the petrous ridge and invade from lateral. This is easier from a surgical point of view because the nerves are on the far side of the tumor. And an occasional one begins from the orifice of the jugular foramen itself. This is the preparatory start. One has to open up the upper neck. This, for those of you in neurosurgery, you can see the sigmoid and the auditory and vestibular apparatus. And here's, the basics here. You can see the facial nerve comes right over the jugular bulb here. Here's the pes anserinus. We're looking here at the middle ear where the tumor often shows. And here you can see the button that's at the base of the middle ear doing an inferiorly based flap. A mastoidectomy, the balance canals, the sternocleidomastoid is removed, as is the mastoid tip. There's then a technique which I introduced with Miles Pensack called the fallopian bridge technique. Many have recommended rerouting the facial nerve. I'm not a champion of that. One needs to decompress the sigmoid sinus to get proximal control, and then skeletonize the facial nerve underneath it this way so that you have a fallopian bridge giving you full access to the jugular bulb. As you can see here, notice that when the tumor is fully extracranial, we retrodissect here, leaving a shelf of bone, and then use a sponge of Surgicel to occlude it. You want to do this early because it reduces the bleeding and the vascular inflow. You do not want to ligate in the neck until immediately before tumor resection. Some have advocated pushing the facial nerve forward for a better view of this area. You certainly can do that, but the risk of neuropraxia or injury is significant, and I just find it's not necessary, that I can take out even tumors with large intracranial and extracranial components, leaving the facial nerve in situ. And this illustrates the concept of facial nerve rerouting. If you leave the ear canal in, you don't really gain anything. If the ear canal is gone, you can push it all the way forward. I really don't practice this today. On rare occasions, and we'll talk about this for basilar artery aneurysms, I will remove the whole cochlea and everything, and you need to push back the entire facial nerve, cutting the greater superficial petrosal. And this leads to a complete facial paralysis, which comes back with some synkinesis. So this is a typical glomus tumor. They grow inside the vessels. They don't stick to the walls of the of the sinuses. We've controlled it here. We've tied it in the neck. One begins to take it out. Usually it's been embolized, and then you remove the rest of it. Now, much of the time one needs to open in the neck, of course. Here's the ascending pharyngeal artery coming off the external carotid. This is typically the major artery. It's much larger than this in a glomus. You have to clip it off or cut it and tie it. Here you can see this is at the level that connects. This is the lateral process of the atlas with the vertebral coming over, and you can see the lower cranial nerves, and I won't dwell on the details. Here's a typical larger glomus jugulare, and you can see having tied the jugular vein below, opening it up, and then what you notice as you remove it from the medial wall, there's a series of openings which are the inferior petrosal sinus. Now, I'd rather, when having that removed, have those squirt, because sometimes the tumor goes through there, and you can see gazing through that, that's where 9, 10, and 11 come through. And when it grows through this is how you end up getting entrapment of the nerves and lower cranial nerve paralysis, particularly the 10th nerve with vocal cord palsy. And so if you remove it and you end up having no bleeding, and of course your imaging has suggested the medial neural component, I tend to leave this if the nerves are intact, because giving someone an acute 9-10 palsy is pretty serious in terms of aspiration afterwards, and one can always use radiation if necessary here. If you try to dissect them out, as we would dissect many other nerves intracranially, they're very small filaments and they're densely adherent and run through. I don't recommend making that attempt. With regard to the carotid artery, typically if it comes off easily, I'll just take it off. If it gets complex in its dissection, I will thin it and bipolar it, and that's just fine. We'll follow it along. You don't want to risk a carotid rupture. Of course, the carotid artery within the petrous bone is not thick like it is in the neck. It's just adventitia on intima with no media. It's more like the jugular vein, and you really don't want to create a carotid artery lesion. In terms of the intracranial part, again, if this sinus is already occluded from the tumor, one can take it out and get a very wide view all the way down from 11 to cervical and cranial, all the way on up to the 5th nerve. And, frankly, the intracranial parts of glomus tumors are some of the easiest to remove. They don't usually stick to things very much. What you don't want to do, for the neurosurgeons in the audience, is go in with a retrosigmoid and take a bite out of the top before you've tied off the vessels in the neck and removed it in the skull base, because it will ruin your day with some very explosive bleeding. But once you've removed the base portion, then it's dry pretty much, and you can take it off, and it usually can be removed off the brain surface quite readily. Schwannomas live underneath the vein, and I will tell you, if a dominant sigmoid is widely patent, I will leave these be or radiate them, because if you have to take a dominant side or even a codominant, you risk inducing pseudotumor cerebri. And so I don't like to take widely functioning sigmoid sinuses unnecessary. And there's no way to get at this without doing that from my point of view. So here's one where the sinus had been occluded, so it's been tied off here. And in the case of the going intracranial, I actually place a ligature around it in this way. And here we're dissecting it out of the foramen. It's certainly easier to save the nerves when they're on the far side than they are when they're between you and the tumor. I will say in jugular-foramen tumors, I can almost always save hearing. I don't feel, as has been advocated by some, that you always close the ear canal. Usually the auditory apparatus can be preserved. Now, what about tumors that invade the jugular foramen from its intracranial aspect, particularly meningiomas? So here we can see a meningioma of the posterior fossa going into the neural jugular foramen. From the intracranial perspective, here's 7 and 8, here's 5, the cerebellum back here, and here's a typical acoustic. So we open that canal, and as we'll see, you can open Meckel's cave in the same way by analogy, so that one can drill open this ledge. And for limited amount of tumor going into the jugular foramen, if the nerves are favorably positioned, one can remove some in that way. Now let's transition on over to Meckel's cave, a fascinating region, and you can rationalize what approach is optimal based upon where the tumor lives. Now, when I think about Meckel's cave, I think about its dural envelope, and you can see here the petrous surface in yellow, the tentorium in green, the clival dura in orange, and here's Meckel's cave in purple with V1, 2, and 3. And from above, you can see the tentorium, petrous bone, clivus, and here you see the purple of Meckel's cave and then abutting the blue of cavernous sinus. So it's important to keep those in mind. The two common tumors traversing this area are schwannomas that can be middle fossa predominant, posterior fossa predominant, or bilobed. And each of these has a different approach. Similarly true for meningiomas. These were recognized early by Cushing and Eisenhardt in their 1938 book as the Gussario-Petrus syndrome. It's a fairly hot spot of arachnoid granulations where we see a fair number of meningiomas in this area. I tend to name them by the surfaces that they're on. So this is a petroclaval meckelocavernoma in my lingo. Now here's one that is posterior fossa predominant. It's a trigeminal schwannoma, a small part on the middle fossa, and we would approach this retrosigmoid. And in going in retrosigmoid, we will, just as we would for the internal canal and an acoustic neuroma, we will dissect out the bone here to get this small portion within Meckel's cave. So with a diamond burr between the inner ear, come up, lift the petrosal sinus out of its groove, and you can actually chase it northward. Now, the reciprocal of this is a larger middle fossa. And again, here you would do a temporal craniotomy and remove the apical petrous bone. So here we're seeing temporal craniotomy extradurally coming down on the floor. This is a retractor that I use that I designed with my colleague Larry Pitts up at UCSF. It's you have to make it custom, but I find it very, very helpful for extradural retraction of the temporal lobe. And here you can see this is what would happen for an acoustic neuroma. This so-called Kawasi's triangle, which of course is a rhomboid, it goes from V3, foramen ovale, to the inner ear. And by removing this medial petrous bone in the ridge, one gains sight planes to the upper cerebellopontine angle and across the midline of the brainstem. And so here we're looking at that bone that's been removed, and you can see here the basilar artery, ipsilateral 6, 5, and 8 entry. And this will allow you to complete the resection of a schwannoma that goes through in that way. Now, when you have a bilobe schwannoma or bilobe meningioma with large components in both middle and posterior fossa, this is where a combined approach is necessary. Now, the classic teaching from the 1930s was you do a hole in the posterior fossa and the middle fossa, but that's very traumatic. So instead, we do a pre-sigmoid craniotomy in continuity with the middle fossa craniotomy. And because many of these patients have normal hearing, we don't remove the audiovestibular apparatus as a translabyrinthine approach would do, but rather do a retrolabyrinthine approach. And what does that look like? It simply hollows out the petrous pyramid, leaving the inner ear intact. This would be a small opening if you did this. I don't use this in isolation. I only use this when we also do a temporal flap. And this allows us to connect the middle fossa with the posterior fossa. Here's the endolymphatic sac. So once you've opened the posterior fossa dura and the middle fossa dura, protecting the vein of Lebet, you begin cutting the tentorium. And as you come down through the tentorium, right at that edge is where the fourth nerve is. You have to be very careful to under-dissect and identify 4. Of course, I've mentioned already about the importance in doing this maneuver of identifying the course of Lebet and avoiding it as you reach the tentorial incisura here. And we've seen that before. This is the exposure, the retrolabyrinthine exposure, and now with the middle fossa, and you're seeing the midbrain in 4, the 5th nerve, 8 and 7 cerebellum pons here. And so if you remove the labyrinth, if they were deaf before, you can get an augmented anterior view. You see the basilar artery, usually not necessary. So this is a typical approach to a bilobed 5th nerve schwannoma, posterior fossa component, middle fossa component, covered by the dura of Meckel's cave, V3, V2, V1, cavernous sinus here. And so removing the posterior fossa part, using a 12 blade cutting up to open that stout dura, and then dissecting out, ideally preserving as much of the fifth nerve as is possible. Now, let's talk about rationalizing a series of different tumors that are ventral or ventrolateral to the brainstem, and ways that petrosectomy might augment or separate from a retrosigmoid approach might help. So I think of this in terms of three zones. The top two zones are divided by the tentorium cerebelli. The bottom two zones are defined by the lowest you can reach in a transpetrous craniotomy. You really can't get to the foramen magnum route. The retrosigmoid approach or transcondylar approach is necessary for that. So you have some pure type lesions, but you also have some combined lesions. And a lesion like this is going to require a lateral approach to foramen magnum, as we'll discuss. Now, the shape of a ventrally situated tumor, in this case, call it a clival meningioma. It can be on plaque or it can be globular. It depends a lot. When it creates a laterality like this, you don't need to do as much petrosectomy. In fact, this kind of a tumor, we might go retrosigmoid because the brainstem has been tilted to a favorable angle. But if you go retrosigmoid here or here, particularly in these thinner tumors which haven't retrodisplaced the brainstem, it's tricky. Now, I'll make a second point here, and that is about the location of these tumors in relation to the basilar artery and its all-important perforators. When it's pushed back like this, it's favorable. When it's enclosed and close, often you can dissect it away or leave a small portion there. This is the scary part, is when the basilar artery is pushed off the front. If you come here and gut this out, the fibers that the small branches that are nutritional to the central pons are at grave risk. And I really worry about major debulking or radical removal of these types of lesions. And I've learned this the hard way about, pontine strokes from that kind of a finding. Now, to illustrate the retrosigmoid approach in a tumor such as this, you can see the brainstem is interposed. You really can't get a good view here. If you remove now the labyrinth, you get a better view, and usually you could remove this tumor with a translabyrinthine approach. But if it's really well across the front, what we'll do then is take out the cochlea and the ear canal, closing the ear canal, skeletonizing the back end of the carotid, closing the Eustachian tube. You can come across the front looking at the basilar artery, vertebrobasilar junction, and both 6 nerves. But you only do this, there's a price to pay of unilateral deafness and at least transient facial weakness in this. And this is not used so much for tumors occasionally, but more often for the rare vascular lesions that can't be handled endovascularly in the mid-basilar artery section, which is so difficult. And I've done this not many times over the years with my colleagues in vascular surgery, where I'd make as big an opening as possible. And you realize you can't make a small opening because they have to get a clip in here for these. These are obviously very serious lesions, and it's a very tricky kind of surgery. Sometimes these petrosectomies are used for exophytic extraaxial lesions, but mostly they're for extraaxial lesions of origin. Now, let's take a look at a zone 1-2 tumor. You can see here it's a meningioma of the clivus pushing back midbrain and pons. And these tumors can connect zone 1 and 2 either by being tentorial in origin or going through the incisura or through the tent. Let's talk about a meningioma that did this. And this is a fairly typical kind of meningioma. These are not rare. It's on the clivus, the petrous bone, through Meckel's cave and into cavernous sinus and pushing up on the temporal lobe. And here we've done a retrolabyrinthine subtemporal approach. Here's the 4th nerve over the top, cavernous sinus. And the rhythm of this, I'm not going to be retracting middle fossa and posterior fossa at the same time. I'd like to begin in the posterior fossa and debulk it here. And you can see here 7 and 8. We'll open that up. And once we've debulked it some, I always go for the vascular base of the meningioma. And so going along the petrous bone and the floor here, it often will have a number of squirters, and that either using a diamond burr without irrigation or bone wax to close them off. If you've done this, then you can come back and begin to dissect off the the brainstem with much better hemostasis and therefore much more organized microsurgery, dissecting forward towards the orifice of Meckel's cave where it's going through, as you see here, and then and only then beginning to retract the temporal lobe. I don't like to retract it forcefully, ideally just gentle support. The cerebellum handles retraction very well. The temporal lobe is much more sensitive, and the less is more, and giving it an occasional drink. And here you can see opening the roof of the tumor using a cavitron here, taking the fourth nerve off, opening the Meckel's roof, which in meningioma is often very thickened with a 12 blade, cutting away. I have some special heavy scissors here because these are often very tight, and then dissecting it forward all the way up to the cavernous sinus. And then I will say, if there's a bit on the cavernous sinus, typically we'll leave a little plaque. You can see the same tumor here, because of course you start getting into 3 and 6 and 4, and the likelihood, the fourth nerve, of course, is the one most vulnerable here. But you don't want to get 3 and 6 as well. And we can leave a little bit there and watch it and use radiation if necessary. Of course, we're monitoring the extraocular nerves. Now, let me move on to an area more familiar, perhaps, to the otologists, neurotologists in the audience, the petrous apex. Petrous apex is basically that part of the petrous ridge that abuts the clivus medially and the inner ear laterally. And the most common lesion there is the cholesterol granuloma. My theory of this is that these are exceptionally pneumatized temporal bones, amongst the top 2 or 3% of pneumatized. And these pneumatic tracts have intermingled with the lakes of vascularized marrow, and the marrow oozes into it, leading to an anaerobic breakdown of blood, releasing cholesterol and causing bone erosion. Most of the time, these are drained back into the temporal lobe, or as we'll see, into the sphenoid sinus. For the otologist, typically the infracochlear route between the carotid, jugular bulb, and the cochlea at the floor. There is an intralabyrinthine route. It's deep field of action and tricky to do. There are occasional anatomic reasons to try this route. The subcochlear approach involves drilling out the tympanic ring extensively and going down and identifying the jugular and carotid. There's a triangle, and then entering in and trying to create a drainage pathway to the middle ear in that way. And you end up with a large-looking eardrum at the end. Now, there are occasions where these are recurrent and they can't be drained laterally, and that's where a middle fossa resection might make sense, where you come in extradural subtemporally and you begin to drill away. And you can see here the anatomy, the cochlea, the greater superficial petrosal nerve coming out of the geniculate ganglion, foramen ovale and V3, and the carotid is typically near here. Here we see drilling away the roof of it and opening it up. And this is a specific case. You can see the carotid artery here, and this is a multiply recurrent and highly symptomatic cholesterol granuloma. And I'm drilling it open. I think I'll advance this a little bit more quickly. And then after having drilled it open, I take an 11 blade to open the cyst. And there's no audio channel because it would be profane, because what happens is, as I'm trying to open the top of the cyst, I end up in the carotid artery. And that is not something, it's the worst complication I've had in my entire career. I happen to have a good video to illustrate. And this patient went on to have a stroke, not from the carotid, but rather from the catheter in the aorta. So this is where, again, using the mini Doppler is very helpful to identify the carotid. One wants to go as far posterior in the entry as possible. And sometimes you remove down to leaving some of the rind along the carotid and under it. Of course, one can go through the sphenoid sinus and drain these, and that's an excellent way to go when the anatomy is amenable. Sometimes they're too far lateral and posterior to enable that. Now, let me go on to the fascinating subjects of the clivus and the petroclaval junction. The clivus means slope, and it's the part of the occipital bone anterior to foramen magnum all the way up to the clinoids, just about the clinoids here. And here you see the clivus from below. Now, the tumor that occurs in the junction between the petrous bone and clivus, the classic, is the chondrosarcoma, arising from that funny cartilage, fibrocartilage around the carotid artery, and it can grow intracranially. This is a smaller one. It very frequently shows up with an abducens palsy for the sixth nerve here and fifth nerve symptoms. Here's a larger one that's indenting the upper pons. Again, we're looking at that rhomboid shaped medial petrous bone that's removed for these, and one gets that view that we talked about a little bit earlier. In these, when they come under the carotid artery in this way, that's when I down fractured the zygoma. Here's the upper frontalis branch of facial and push down the temporalis muscle to be able to get below the carotid. I don't ordinarily down fracture the zygoma for most transpetrous apex approaches that don't go low. Now, most chordomas, of course, are handled transnasally very ably and effectively, but sometimes, and here just showing that, just sort of scooping it out into the suction, but sometimes they recur and sometimes post-radiation they occur. This is a particular case map where the recurrence was, and we thought about various ways of getting there. One can certainly get there from above, but it's a long track down towards the 12th nerve orifice. And so what we did is we designed a pathway here behind the facial nerve, along here. The jugular vein was gone on this side, the sigmoid, I should say. And so we just came right on down, and there is a ramp that allows you to get there. Now, again, the retrolabyrinthine approach, this is the combined approach we've talked about before. Notice this tumor is not a meningioma. This is a chordoma with extensive posterior fossa component. And again, using this combined approach with tentorial splitting, one can open windows between the nerves and then feed the tumor up into the suction and then deflate the retrodisplaced dura, or if it's breached the dura in that way. Not necessary very often, but this can be done for advanced chordomas. Now, when they are down at the bottom here, you can see this transpetrous approach doesn't get you to the lower clivus very well. We'll address that in a minute with the foramen magnum. Now, foramen magnum tumors that are posterior, my neurosurgical colleagues can readily get to those without any partnership. But when they're anteriorly situated, it helps to do a craniotomy that comes forward through the petrous bone, behind the facial nerve, and through the condyle. Typically, here's a ventrally situated meningioma that's pure class 3 below the way. So here's the opening that we were mentioning. Here's what it looks like with the retrosigmoid craniotomy coming forward, and you can see the way the nerves are depicted. We tend to use this type of incision, but there are two variants here. One does the craniectomy as usual, and you can see one then comes forward in the tip of the mastoid here to get to the lower edge of the sigmoid sweep. One then bites off the foramen magnum. Here's the vessel, the vein at the verge, and then begins to go then through down to the condyle, lifting the cerebellum extradurally, removing the back part of the condyle. If you have to remove more than this, they can get instability, and your colleague will perhaps need to do a stabilization procedure at the end of the section. But you can get away with the back part of the condyle. And this is, this is a challenge, because you're looking here at the tumor coming down with all of the nerves. This is, 7 and 8, 9, 10, 11. This is the cranial root of 11 and the first couple and 12 and the first couple of cervical roots. Some people will retrodisplace the vertebral artery. We have not generally done that in my experience but perhaps things primarily in the first cervical vertebra. I'll tell you that, I've worked so closely with my neurosurgeons over the years. Sometimes, say, oh, Rob, would you do me a favor, after we've gotten the condyle and all that, get started on the tumor, would you mind doing the laminectomy of the first couple of, hey, wait a minute, that's outside of my area, but I do think that the team approach is great, because you're at your best for microsurgery for a couple of hours. There's not very much distinction in what my neurosurgical colleagues and I do. We pass the baton back and forth, and we work together as a really seamless way. I think it's really optimal for the patient. For the otologist, I know for the purposes of this talk, we're probably already over time, but I'll put this on the recording for my colleagues. Temporal bone cancer. So when we talk about squamous cell carcinoma of the temporal bone, beginning from the ear canal or middle ear, has a very bad reputation for lethality. That has not been my experience. Most of these can be addressed appropriately with combined therapy of surgery and radiation, not just the soft tissue of the ear canal. One needs to, at very least, do a lateral temporal bone resection. And I think this notion of creating a cavity, like a modified radical or radical, is wrong-headed, because you're about to put in 70 gray of radiation, and osteoradionecrosis is a big problem in an open cavity with exposed bone. So this is how I close the ear canal. I make a circumferential incision. I take a ring of tissue to the pathologist to make sure that we're free of tumor there, bring the tragus to the concha, and then at the end, I bring down the posterior half of the temporalis and sew it to the sternocleidomastoid, being a beautiful vascularized muscle over this area in preparation for radiation therapy. So again, mastoidectomy, opening the facial recess, cutting the incustostapedial joint, removing the incus, coming down along the facial nerve, and then removing the front face of the mastoid and the roof of the condylar fossa, like as you can see here, taking away into the parotid bed, and then coming above down into the glenoid fossa. I do not use a chisel for this. Once I've got this bone all removed, I just crack it forward and take a pair of scissors and it comes out. If there's a question about penetration here, I will dissect out the pes anserinus and take the parotid that overlies the TMJ and the interface here with the specimen. Now, yeah, and you can see here taking a pair of scissors, and these are the temporal artery and vein, and taking that out. Now, once that's out, one has to realize from looking at the MRI and the tumor spread, sometimes it's gone through those fissures of Santorini, down the front face, into the pterygoids and the infratemporal fossa. And here's what I would do there. This is the osteology of that. So here's the ear canal, the glenoid. Things can spread down into these fibers, and you can see it sometimes spreading within the pterygoid muscle. This is spinosum ovale and the pterygoids. And so what I do is dissect out the remaining fibrocartilage of the condyle after removing the condylar head, grab the muscles, begin taking the pterygoid muscles out, come all the way down here to the pterygoid plates, severing V3 and middle meningeal at the cranial base. And this is a good way of getting a thorough clean out of this area. Encephalocele of the temporal floor is the last subject I'm going to put on this particular recording. And those of you who do a lot of otology, neurotology, and perhaps neurosurgery, it's not rare. Of course, probably our colleagues in rhinology see this more often. These people may have chronic hydrocephalus, but you can see it can herniate in the mastoid, into the epitympanum, or rarely into the apical petrous bone. And here, this will cause conductive hearing loss. Sometimes the dura gives way and the brain pushes almost like toothpaste in the middle ear. You can see it behind the eardrum. This is the approach. Unlike our rhinology colleagues, where you can repair most of these things from below, I'm not so sure that works very well in the mastoid, so I tend to do a mini craniotomy, come in from above. This can be very small craniotomy, extradurally lift up, identify the stalk, having opened the mastoid for the lower portion. I don't cranialize these very often unless they're small. What I'd rather do, usually these have infarcted already when you send it to pathology. I usually bipolar across the base of it, removing it, and then do a multi-layer repair with, you see some fascia, often fascia underneath, followed by a piece of the temporal flap, the thin portion, lower edge. When there's a large dural defect, I'll make a dural incision, lift the temporal lobe, and I'll close the dura from above. The nice thing about that, the temporal lobe pushes it down to get a watertight closure, and then fascia and bone. And often I will put hydroset, because where you get a hole and a hernia, it's often looks like someone's hit the skull base with a buckshot. There are all sorts of other erosions. So I'll put down fascia and bone, and I'll also put down hydroxyapatite cement, quite thick often, to protect the floor. Sometimes I'll also swing in the temporalis muscle flap, and you can see here the bone covering over. And we'll leave the ear canal closure, maybe just a quick word. If you anticipate possible CSF leak, you need to close this in an orderly fashion very thoroughly. It takes 45 minutes, and you have to be careful not to button hook the skin. It's a 3-layer closure and an eversion of the ear canal. You cut posteriorly, you take a clamp between the parotid and you cut through the cartilaginous portion. You dissect back out to the conchal edge and onto the tragus anteriorly. Over stay sutures, you pull it through, then vertical mattress sutures, pulling the raw surfaces together all the way out, and then take away some cartilage. And then often you can put a stitch or two on the inside, and then a flap of the temporalis fascia, either from anterior or superior, to cover over. And we'll leave superior canal dehiscence for another day. And with that, I want to thank you very much for listening, and I would be very happy to take any questions.